Good day, everyone, and welcome to our second webinar in Atlas's Continuous Quality Improvement Learning Series in 2021. Today, I am honored to welcome three leaders from California Bridge. California Bridge is working on increasing easy access to substance use care in emergency departments and seamless bridging to outpatient care. Let me introduce our speakers. First, we'll have Arianna Campbell. She is co-principal investigator and director. Second, we have Alicia Gonzalez, who's a regional director and clinical training lead. And third, we have Loni Jay, who is faculty at Sutter Family Medicine Residency. At this point, I'll turn it over to Arianna Campbell.
All right, thank you so much, Angad. So I'm Arianna Campbell. I am a PA in the emergency department and have been for more than 20 years. I am incredibly excited to be here with an amazing panel. And we are here to talk to you about how we are transforming addiction care, utilizing the emergency department and hospital as an entry point to care. So again, I'm an emergency department PA and I work at Marshall Medical Center. So I work at a rural hospital in Northern California. And I'd like to introduce Alicia, who will talk a little bit about what she's doing.
Hello, and thank you for having me. My name is Alicia Mikolaycik Gonzalez. I'm an emergency medicine physician, and as mentioned, the regional director and the clinical training lead for California Bridge. And I currently practice in the Central Coast of California. And this is a topic that's really special to me to be able to be involved in this work because I actually have a family member who passed away from opioid overdose. So this is a passion project for me and something that I really care about because I think it hits home for myself and a lot of other providers I know. And I'll hand it over to Loni.
Yeah, hi. So my name is Loni Jay. I'm a family medicine physician, and so I do outpatient care. And I am here today pulled into this work from my practice. So I work in the rural foothills in California. And as I started building my primary care practice, I noticed so many people coming in struggling with substance use disorder, and there was nowhere to send them to. So naturally, I had to start becoming part of the solution. And so I've been working in addiction medicine, creating a low threshold, low barrier clinic, which has been a bridge clinic. So I've been partnering with the bridge program to provide outpatient care and work on this really great handoff. I'm currently faculty with the Sutter residency, family medicine residency program to train more providers to take part and care about this work.
All right, so for disclosures, I just wanted to say that California Bridge is a program of the Public Health Institute. None of the speakers here have any disclosures. However, both Alicia and I are paid staff of the California Bridge program. And I did want to say, sometimes you'll feel like they should have disclosures because we're so passionate about this work. And really this comes, I mean, for me, I've worked in the emergency department more than 20 years. And so 17 years of those, I spent not treating patients with the right medication at the right time. And it was really frustrating. And so starting this work has made me so passionate about it that I just have to say, we have no financial disclosures, but sometimes it seems like we may. So, all right. And really the basis of everything that we're going to talk about is this slide here. Addiction is not a moral failing. It is a chronic disease that requires medical treatment. And how I want to frame this from what we're doing in the emergency department and how this is a change is for years and years, we did not treat opioid use disorder, opioid withdrawal with the right medication. Honestly, we gave some supportive medications. We may have sent folks out with a list that may not have been updated. And I want to compare that to some other disease processes. So for example, if a diabetic comes to the emergency department with an emergency like DKA, would you call them insulin seeking, right? I mean, they do need insulin, but their body depends on insulin. Sometimes, maybe because of some unfortunate choices. Many of my patients have made poor choices in their diet, in exercise, in various things that may have landed them really in trouble with their health. And so do I deny them treatment? Do I not give them the most up-to-date treatment? Of course not. My whole job is to give them evidence-based, high-quality treatment. Same thing with hypertension, hyperlipidemia. This is our jam. This is what we do in the emergency department. And so we're really just transforming care to do what we're really good at, which is treating with evidence, right? So again, we are not treating bad people. We are treating folks who may have made some choices that have landed them in our emergency department, and we're absolutely there to treat them with this as the model. So again, it's low barrier treatment. That means we're treating folks that come in asking for treatment. We don't make them jump through hoops. In fact, we don't even require drug screens in the emergency department. Why? Well, anybody who ever works in an emergency department knows that it's terrible to wait on urine, and it's not going to make a difference in what we do. Why? Because it is so much safer to treat a patient with the right medication, and we'll talk about that in a little bit, buprenorphine is what we use, than to send somebody out to return to use and possibly overdose. So again, we're trying to create this low barrier treatment. Then the other part of it is we want to connect the patient in front of us to high quality care. And of course, that is why we're on this talk, is talking about how we do that. And also to community. What I do know after I started doing this work 4 years ago is there are so many great people in my community doing amazing work, and yet none of it was getting to the most vulnerable patients who were showing up in my emergency department. So it's really important from our perspective to connect patients to high quality care and to community resources that are really trying to advocate for patients. And then what we're also doing is we're instilling a culture of harm reduction. Harm reduction should be in every single thing we do in medicine. So this is just part of it. When we treat patients with this harm reduction approach, maybe somebody's not ready to start treatment. Okay, what can we do to keep you safe in the meantime? So it's really meeting patients where they're at and always considering that harm reduction approach. And we have all sorts of programs in our emergency departments where we do that, including giving out naloxone, safe syringes. We have all sorts of programs that we're trying to keep it safe for patients, just like we would do if a patient came in with diabetes and wasn't going to use their insulin. We would try to think of how to meet them where they're at and provide the safest treatment. Same idea here. So really what we're doing is we're trying to tip the scales, right? So we want to make medical access to buprenorphine. We want to make that easier than street access to drugs. How beautiful would that be? And how many lives would we save if we could do that? So this is really, this program in its simplicity is just trying to create easy access to the right medication for the patient. So how have we done this? What have we done to date? Well, goodness. So over approximately a little more than 2 years, from April of 2019 to June of 2021, we have Substance Use Navigator. So this talks about encounters with navigators, 66,000. And this is in 86 sites across California. There was more than 42,000 patients who were identified with opioid use disorder during this time, and almost 19,000 encounters where MAT or buprenorphine was prescribed or administered. So what we do know is emergency departments are an incredibly important access point to provide this high quality care to patients. So what does this mean? Kind of like boots on the ground. You're working your shift, like I work my shift in the emergency department, or you see a patient in follow-up who was seen in an emergency department. What it used to look like, and I want to talk about this because this is important. Again, 17 years of my career I spent doing this another way. And what that looked like is not that I didn't care, but I didn't know what to do. So I was treating folks with supportive medications, like something for their nausea. I was treating them with like clonidine to see if I could decrease the effects of their withdrawal. I was giving them a list that had been copied. You've all seen the list. So it's been copied like 20 times. It's kind of like off kilter. There's a lot of graininess to it. And really what it looks like is there's all of these resources. So I feel good. I say, here, go find your self-care. This is going to work. And the feedback I got was, did you know that they told me that I can't get in for 6 months, that I need to quit using heroin before they'll see me and can't have any withdrawal symptoms, right? Or they'll only take pregnant patients, or they'll only take this one insurance, or I have to pay a lot of money before they'll ever take me. Could you imagine if that were the follow-up that we were giving to patients for other medical problems? Of course not. But when we change the narrative, when we change what we're doing in our emergency departments and hospitals, what you find is, I mean, these are quotes from actual people. So thank you. This is the best I felt in years. That was very shortly after giving the patient the right medication in the emergency department. We've had patients' families say, thank you, we have our mom back, who actually came in to tell us that. And actually from other clinicians. I've had other clinicians who were really feeling just so fatigued from not having the right thing to do for their patients and have said, I finally have a solution for my patients. So instead of feeling frustrated that I'm doing the wrong thing, I feel like I'm making a difference in their life. And so these are real stories. So Loni, I know that you also have had a similar experience in your career, and I'd love you to share how the narrative has changed for you.
Yeah, so I get to see patients just the day after. I get to see people who have been stabilized in the ER and come for next day follow-up with me in outpatient care. And I get to see the day after that emergency providers don't always get that feedback. And it is, honestly, it's the best kept secret. It's the best corner of medicine, having the opportunity to practice within this addiction medicine corner, because patients show up for their visits and they say, I feel like myself again. I feel hopeful. I see a route where I can stabilize. And so this hope that people come in with is really such a pleasure to be part of. Anyone that's experiencing burnout in their career, this is the cure for burnout, is being able to take part in these big wins that come in addiction medicine. So that's what's so wonderful about my job. The bad news, the reason that we are here, is that overdose deaths are increasing throughout the years. You've all seen this slide from 2017. It's a CDC slide, and it shows that, the first opioid epidemic, that was prescription pills, people got hooked and started misusing and abusing opioids, and then quickly turned to heroin when that became cheaper and easier to get a hold of. And now we are in this third wave of this opioid epidemic, which is fentanyl. And we are starting to see this everywhere. I think it's really touching all of us that are in this field, that we are seeing people coming in more withdrawal, sicker, higher overdose rates with fentanyl, and finding it in many things that they did not anticipate. And this is the most recent data. From the last one was up to 2016, and this is beyond, seeing a continued rise in fentanyl as the drug of choice. And the concern right now is that we don't have, with COVID and this pandemic and everything that's going on, our ERs are overrun. It's been very challenging meeting the health needs that are coming at us as providers, but even more so, this is a time where we need to address unstable substance use disorder. So while people are struggling with COVID, they have not had access to care. It's been harder to get into programs. There's been a 93% increase in 2020, 93,000 deaths, which is a 30% increase compared to 2019. And the extra challenges that have come from COVID, that people are now using alone where they didn't as much before. There's an unstable supply. So where before people had a stable dealer, they were getting substances from, now they're finding a new source or trying a new type of opioid. Fentanyl is often easier to get than heroin at this point. And so people are relapsing and continuing to struggle. And that has made things very challenging for people. And so we are really in an all hands on deck situation. So managing substance use disorder is not just an outpatient problem. It is not a problem for just, counselors need to address this. This is a medical disease that every aspect of our healthcare system encounter patients struggling with this, and we all need to be part of the solution. And so this is the folks at Highland Hospital, just highlighting how they have pulled in all members of their community to be part of their team to really assist with these handoffs. So they've called in the police department, they've called in members of the homeless outreach team, and all of us engage with our community partners, probation, parole, CPS, and all aspects of care to be part of the solution rather than provide siloed off care.
And so that leads us to talking about what we do here with the California Bridge model, which is that we created this pathway to having low barrier access to care in the emergency department or wherever the patient is when they're ready to start treatment, with a direct warm handoff, not just a list of resources, but a warm handoff to whoever's going to do their ongoing treatment for them. And then with a community of providers that are ready to help fill in those other safety gaps and address some of those barriers that they approach. So as we go through the rest of this presentation, we're going to highlight roughly 7 of these key principles that we think are essential. And it turns out, as you shouldn't be surprised, they absolutely overlap with some of the Atlas quality principles, which we'll recap at the end. And so naturally, you know, West Coast and East Coast, we've come to the same conclusions about what are the most important things when it comes to treating our patients. And because everything is so much easier when we focus on the actual user, the patient, we'd like you to meet this hypothetical patient named Javier. But in reality, Javier is an amalgamation of a lot of very real patients that Arianna and Loni and myself have taken care of. So we're not really making it up, we're sort of making him up, but all these are very real things. So Javier is a 24-year-old male. He's got a history of heroin use disorder, you know, and he's actually pretty motivated to get his life back on track. And he's been trying to get help for maybe 3 months. He went to his family care provider and they told him, you know, you really have to go see a specialist. And here's a packet of a list of people that do this work. Well, Javier doesn't have a car. And the closest addiction specialist was like 20 miles away or, you know, downtown. And he lives out in suburbia and can't get there very readily. Not to mention, he's trying to like get and hold a job to be able to have a stable life. And he can't take, you know, 4 buses with transfers to get downtown for this care. And he doesn't have access to a nearby methadone clinic either. So then he goes through the other resources on this handout. Half the phone numbers are wrong. Like Arianna was describing, is that, you know, we don't update those things very often. Half of them are wrong. The others tell him, hey, we have no appointments. Some of them now it's COVID, so they're not taking new appointments or walk-in visits. And so also he has to be clean for 2 weeks, but he's worried about being clean because going through heroin withdrawal is extremely painful and a really unpleasant experience. You know, if you've ever seen somebody in like full-blown withdrawal, it looks miserable, and I wouldn't wish that upon anybody. He also then was told by other places, because he's not insured, well, we can't get you insurance, and also you have to pay out of pocket up front. But remember, he's trying to barely hold on to this job that he's struggling to hold on to because he can't get to these appointments unless, you know, and he can't pay for them. And so it's just kind of a terrible thing. And so he feels dedicated to quitting. And he's like, look, I am in withdrawal. I feel like crap. I need help. I'm going to go to the ER. And so Javier comes into the emergency department. Now, several years ago, if we're being really honest, what would Javier have said? He'd walk into an ER. Maybe this is what it looks like in their trauma bay. Everybody's busy. People are running around. They're like, what do you need today? You know, they're running through all the standard nursing screening questions, which include random things like, do you want to hurt yourself? Because that feels super relevant to everybody when they arrive to the ER, just the bombarding of all of what it feels like to walk in. And so he maybe would have said, oh, I'm here for like, you know, I've been vomiting and having diarrhea. Because it's a very stressful experience. He's ashamed of his drug use. He's not sure that he's going to be welcome there. And frankly, has many years of history where he's gone to the ER for things and been treated not very well, and heard people in the hallway talking about him as an addict, or let's kick this guy to the curb, or let's get him out of here. Direct quotes that he's heard about it before, or with an abscess, and people have rolled their eyes and given him some shade about his drug use in the past. And that's what he's experiencing. So that's normal, right? That's like what used to unfortunately be normal in healthcare. But now with this new model, let's say Javier walks in, and on his way right before the triage station, he passes this sign. This is an actual sign from Marshall, where Arianna works, with a California Bridge program logo in the bottom. And it literally just says, are you using pain pills or heroin? We can help you, ask us. And Javier's like, oh, wait, hold on. Straight up, I feel like maybe I can be honest. Like, the sign says that I can talk about this. So then he gets to the triage nurse and he says, you know, I saw the sign. I'm withdrawing from heroin and I think I need help. So already from the get-go, we're talking about a very different experience for this patient. And the reason that this is important, Arianna, I would love for you to talk about this. Why is this the timing that matters so much to this patient?
Well, this is actually could be a transformative moment in Javier's life, right? Javier is seeking treatment. But what if Javier's first visit to the emergency department was from an overdose? So let's say during COVID, Javier, you know, there's an unstable drug supply. He used something that he hadn't used before and overdosed. So he comes into the emergency department that way. Javier's risk of dying in the first year is enormous. In fact, 5.5%. And yet, if I treat him with the right medication, I could decrease his risk of dying from anything by more than 50%, right? So it's incredibly important to treat him at this time. The other thing I want you to look at in this slide is his risk of dying just in the first month. So 22% of those who died, well, 20% died in the first month, 22% of those died in the first 2 days. Think of any other medical problem that we treat in the emergency department, and with that risk of mortality, it's incredibly important that we have something to offer Javier other than, wow, that was a bad mistake. You know, typically Javier, if he came to the emergency department post-overdose, he would feel ashamed. He wasn't planning on coming for treatment that day, but his risk of dying is very real. And we can do, you know, if we utilize our model of offering treatment, of actually giving him medication, giving him, you know, harm reduction supplies, we can make a huge difference in this statistic. So this is an emergency. This is our job. And our job is to decrease mortality. And we can do that by having systems in our emergency departments and available systems to refer to care as well. So again, I just want to acknowledge that for those that are not seeking treatment, we still can do something about this. And sometimes it's, as Alicia was talking about, sometimes it's actually being kind, meeting a patient where they're at, not being judgmental, and making sure they know that we can treat what's going on that particular day and decrease their risk. So,
and Arianna, something that Loni says that I think is worth highlighting here is, in the ER, there are a lot of things where when we know the risk is this high in the next 48 hours, we admit the patient. Think about like unstable angina, right? We admit those patients to trend their troponins and watch them. A TIA, we know their risk of stroke is very high for the next 48 hours. So we admit that patient. And here we are with another disease. I'm not saying we should admit these patients, but we should take them equally as seriously. We know that when you present this way, your risk of death is extremely high in the next 48 hours. And we should take that equally as seriously. So Loni always says that. And I think it's really a nice framework to think about this.
Yeah, and the baseline is that we've heard, well, is opioid withdrawal an emergency? Is it deadly? Absolutely, yes. So what's really important here? Well, we want to make sure that somebody like Javier, who either came in for treatment or has been referred after an overdose, we want to make sure that he is able to access care. What I can tell you, who we're seeing in our emergency departments are folks who have trouble accessing our system. The system that we have in place is super complex. I have trouble navigating our system when I'm trying to get an appointment or with my family members and trying to work on, you know, getting there on time and picking somebody up and making sure that the right, you know, it's very complex. So picture somebody who's in withdrawal, somebody who is suffering, somebody who is in just the deepest part of their addiction. And so what we know is avoiding strict appointment slots is really important. Flexible drop-in access does lead to better patient engagement, superior outcomes. Like, there is no Uber or Lyft in my community. Folks have trouble getting there. We have like one bus and it's always late. Sorry if anybody is watching from my community, but it is truly difficult for patients to get to somewhere on time. And so making patients fit into this, you know, into this system that's really not advocating for them can be very problematic. And the other thing is welcoming patients with a medication-first approach. So I can tell you, when I'm treating somebody like Javier in my emergency department, I don't make him jump through a lot of hoops. So I try to get medication on board as quickly as I can, because if he's coming in withdrawal, he is suffering. He is miserable. And so really making sure I stabilize him, just like we do with other emergency medical conditions, stabilizing with medication so that then we can get him into a better place to get treatment. And so what's this treatment? We have a few different options. I'm sure that a lot of people watching this are very familiar, but I just want to review and kind of talk about what we do in emergency departments and hospitals. So certainly there's methadone. Methadone is that full mu opioid agonist. Again, it's usually taken as a solution, and can we give this in the emergency department? Well, certainly. However, it's a little more difficult because there's a lot of regulations in terms of getting methadone. So you have to usually go to a specialized clinic daily to get this. In my community, we had no methadone clinics for years and years and years, and now only have a satellite clinic. So sometimes access can be very difficult, especially in rural situations. And certainly naltrexone would be an option. It's not a great option in the emergency department because folks have to go through significant withdrawal to get there, and that is very difficult for patients to get to. So this is not something that we typically are giving for opioid withdrawal in our emergency departments. I do give it for actually alcohol use disorder. So really the star of the show here is buprenorphine. So I'll talk a little bit about it, but it's a partial mu opioid agonist. So this is why we like it so much, because first of all, in my department, I can give this medication sublingually. So it works quickly. And even if somebody has been vomiting, they're able to have this absorbed in their mouth, and it very quickly alleviates their withdrawal symptoms. In fact, my patients typically are getting better within 15 to 30 minutes. So it's also the reason I like it so much. I actually post overdose, I consider it airway protection. Why? Because there's a ceiling effect on respiratory depression. So so buprenorphine has this very strong affinity for the mu receptor, right? So other things, let's say, I load up somebody with buprenorphine in the emergency department, and I really try to do that again for safety reasons. And then they go home and think, oh man, I left some heroin on the seat. I'm gonna try that. If we load them with enough buprenorphine, that buprenorphine has such a high affinity for that receptor that they really don't get effect from that heroin. And we've also made sure that they will keep breathing, right? Because it has a ceiling effect on respiratory depression. If we give it too early, it can cause precipitated withdrawal, which I know a lot of people that concerns them. What I can tell you is we're used to that in emergency departments because we intentionally precipitate withdrawal all the time if somebody overdoses, and we know what that looks like and are certainly comfortable treating that. The other reason, though, again, we like buprenorphine, it has that ceiling effect also on sedation. It blocks those other opioids, it displaces other opioids, so we're careful. And what the other thing I like, and the reason I usually try to load a decent amount of buprenorphine before a patient leaves, is because of that half-life. So it lasts for 24 to 36 hours, and sometimes I'll load up to 24 to 32 milligrams so that somebody has even longer effect, so that if they have trouble getting to the outpatient appointment, that buys them some time, or maybe they run into some problems at the pharmacy. I've created some safety for a longer period of time. So again, any clinician can order buprenorphine in the emergency department, which is why this is super easy to do, like right now, to connect with your emergency department, because anybody can order it, but you still need an X waiver, which we'll talk about, in order to prescribe it. So what's our, NNT? We always look at NNT, like how many patients do we need to treat for success? So just compare this, like aspirin for heart attacks. This is like standard baseline, care here, and it takes 42 to save a life. So we think of warfarin or Coumadin with atrial fibrillation, 25 to prevent a stroke. Steroids, standard of care. If somebody comes in with COPD exacerbation, you treat 10 people to prevent a treatment failure. So now look in terms of cardiac arrest, right? 2.5 to save a life. So now buprenorphine for opioid use disorder, it's 2 to retain in treatment. That's all you need to do to have a success in treatment, is to treat 2 patients. And we've actually found this number reproducible across the board. So at the emergency departments and hospitals who are doing this, when we give the right medication at the right time to the right patient, that number needed to treat is 2. Super important. All right, so I love talking about this article. This is Gail D'Onofrio. This was published in 2015 in JAMA. Though, this could be your first time hearing about it, but what we do know is that when she did the only randomized controlled trial. Why? We won't do this again because we know how much this works. And what she did is she gave patients either buprenorphine, or they did a brief intervention and referral to treatment. And what she found is that if you gave buprenorphine in the emergency department and referred to treatment, you doubled the likelihood that patient would remain in treatment at 1 month. Doubled. So this is huge. And again, we won't withhold this treatment anymore because we know it works. And quite frankly, I couldn't live with myself if I didn't offer somebody this treatment, knowing how much it works. So, and I have to say this same, Gail D'Onofrio did this at Yale, but we've done this. I work at a rural hospital, and our numbers for retention and treatment at 1 month were about 83 to 84%, and have varied, but most of our patients follow up like 97% at some point. We're following up. And Alicia, I don't know if the statistics are the same in your facility, but we found these numbers reproduced at all sorts of different hospitals across the board, from urban academic centers to rural hospitals. So again, This is evidence-based treatment.
Yeah, and in the work that I do, I actually oversee the start of treatment at 25 different emergency departments through California, all different types of clinical settings. And what Arianna is saying is completely true. It doesn't matter the setting, as long as, especially if you have that clear delineation of how they're going to get that ongoing care, which we'll talk about in a second. But as long as that piece is there, sometimes, yeah, our retention rates are higher than 78%. They can be 80 or 90, depending on how smooth that transition is. And we talked a lot about buprenorphine, why we like it, why it's the right med for the ER, and we're not trying to knock the other meds. There's a place for all of these medicines in treatment, but we use buprenorphine because of that safety profile. And so we want to take a second to clarify this X waiver situation. There's a lot of misunderstanding out there, a lot of confusion. It used to be, so every provider with a DEA license, regular DEA, can give buprenorphine right there in the ER or in clinic or whatever, a single dose in an acute care setting or inpatient in the hospital for as many days as they're there. No one needs anything special to do that. The hospital doesn't need something special. The pharmacy doesn't need something. You don't need something. Any PA, nurse practitioner, or physician with a DEA license, period. The only time that the X waiver kicks in has to do with discharge, an actual outpatient prescription that the patient will fill at the pharmacy. In order to get that filled, the prescribing provider must have an X waiver. It used to be that you had to complete a very significantly long training. For PAs and NPs, it was 24 hours of training. And for doctors, it was 8 hours. And I mean, it was good information, but it was painful and really kind of seems silly, right? Like, I can write somebody extended release morphine for pain control with no special license. But to start somebody on treatment for their opioid use disorder, I had to have a special license to fix the problem. That made no sense. So thanks to a ton of advocacy work that's being done by all kinds of organizations, we're moving towards getting rid of the X waiver. But as of today, August 2021, it still exists. But all you have to do is apply for it. There's no more class or special training you have to do. You just have to go to the website. And to be able to do that, I'll pause here. Please pull out your phone, scan this QR code, and it'll go to the California Bridge guide for how to sign up. It's very simple. And if you're outside California, the guide is the same. This is a non-specific to your state. It's a federal SAMHSA run program. So just go ahead and scan this QR code, follow the steps to get your X waiver. It literally takes like 5 minutes. It's very, very fast. So everybody should do that. So I'll linger here while I say one more thing, which is we keep talking about buprenorphine, but you'll notice that on our slides, it says buprenorphine naloxone with a hyphen. There are multiple different brand names for buprenorphine. You'll often hear patients call it Suboxone or Subutex. There's different kinds. Suboxone is the brand name for the combination buprenorphine naloxone tablets. And those are either dissolvable tabs in the mouth, like Arianna said, or they can be a buccal and in the cheek film, like a Altoid strip that dissolves in your mouth. And the reason that has naloxone in it, naloxone is inert when it's taken correctly orally. But if somebody were to try to abuse or divert their Suboxone, their combined pill prescription, and say melt it down or inject it, then naloxone kicks in. And then naloxone is stronger than the opioid component, the buprenorphine. So you cannot boil down and get high off of the combo pill. And that's why we like that. It just helps prevent diversion. With that said, I will tell you, at least in my community, a lot of times, not 100%, but patients who are buying Suboxone, the combo on the street, are actually trying to be in treatment. And so I'll meet people who say, I've tried Suboxone, and I say, well, what doctor gave it to you? They're like, no, I was buying it. So I was trying not to go into withdrawal, but I had to go to my job. You know, I wanted to be able to go to my kids' soccer game, but I didn't want to be withdrawing at the soccer game. And so I went and I bought, you know, buprenorphine, Suboxone for $5-10 a pill. And so there is a desire for people to be in treatment. Don't be surprised if your patients have tried Suboxone before, even in a diverted way, but maybe they're not trying to abuse it. Maybe they're just trying to be in treatment. And that's another reason we want to make that more accessible. And that's why you have to have your X waiver, is to be able to write those prescriptions for people. And so that brings up, you know, one of the many, many barriers that currently exist to treatment. As I mentioned, it's easier for us to prescribe morphine and hook a patient on opioids than it is for us to treat them to get off of opioids. And we are trying to change that. So getting rid of the barriers to the X waiver is step one, but there are so many. First of all, don't be afraid of polysubstance use. A lot of patients use multiple substances. The only ones you really have to think about in the acute moment in starting treatment is things like benzodiazepine, Xanax, Ativan, alcohol, things that are also respiratory depressants. Because while buprenorphine has a ceiling effect and is only a partial agonist, and we're not worried about it, buprenorphine combined with other things that are respiratory depressants, that's a little bit more concerning. That doesn't mean they can't be on buprenorphine. It just means you have to be more cognizant of that risk, counsel the patient about that risk, and maybe titrate up their dose a little bit more slowly. And then if they use methamphetamines, doesn't mean they cannot be on buprenorphine. So remember, just because patients are using multiple drugs doesn't mean we can't at least take care of the one. I wish there was a magic medicine for meth, but there isn't yet. Maybe someday. But for now, we should not withhold treatment. I absolutely hate it when organizations mandate that to be a part of their treatment, you have to go to their group therapy or to Narcotics Anonymous or whatever. I think that's ridiculous. Those things are wonderful resources and they should be available to patients, but they should not be a contingency for care, partially because what we've been talking about, a lot of these patients, it's not convenient. It doesn't work. They would have to skip their job to come to these support groups. So you shouldn't mandate that for people. I love having it available and it can be very effective, but you're not mandating extra steps. Or like Arianna said, if you're late to your appointment, you get fired from the clinic. I mean, these things are totally counter what we're trying to do here. And then, same thing, like if a diabetic ate a donut and then showed up late to their appointment, you wouldn't not refill their insulin, right? So it's the same mindset. This is a chronic disease that has a lot of psychosocial factors that we have to be supportive of. And then also using urine drug screens. We really definitely do not advocate using them to start treatment. I don't know that I've ever met a patient that told me I do meth and heroin and they were lying to me. I usually just believe them that they were doing the drugs they said they were doing. And I know what opioid withdrawal looks like clinically, and I can start the medication without a drug screen. So in the ER, not at all helpful. In ongoing care, I have heard many providers talk about how it's helpful in the clinic setting to use it as a conversation piece. And so the important thing is if you're going to do urine toxicology screening, framing to your patient why you're doing it. And it's just to say, hey, this helps me confirm you're using your bupe, but it also it's an honesty moment. Doesn't mean I'm going to fire you. Doesn't mean I'm going to take your bupe away, but it helps us just have a conversation. Loni, I would love to hear some of your thoughts about from the clinic side, other barriers or more on the tox screen that you're experiencing with your patients.
Yeah, absolutely. So we see people continue to have barriers keep them from stabilizing in a lot of ways. That is this disease process. So like a lot of diseases, we don't just fix it and it's done. It's a process. And when there are people that come in for care and aren't meeting our expectations, my team knows that that is an opportunity for us to look around and say, how are we failing this patient? What do we need to do to lower the threshold of our expectations, lower the barrier so that we are meeting this patient where they're at and we're providing the care they need? Because if we have placed something like you have to make it on time to this clinic visit and they don't make it, if we have set this expectation and they don't meet it, then they're out there and they are left alone with their disease process. They are on their own to try to stabilize. So any way at all that we can pull people in is the right thing to do. Usually if there is a patient that has hesitancy leaving a urine drug screen at the start of visit, staff knows to grab me and I go in and have a conversation. And by the end of the visit, I don't usually need a urine drug screen to know what's going on. And I think that should be our goal. That should be what we are striving for with our patient, with our relationships, that we have developed relationships of trust where they know it is safe to struggle. It is safe to not stabilize at once and be done with it. And that it's a place where they can come and we can talk about what's going on. Because like any disease process, it can take a little bit of time. People aren't going to stop eating sugar just like that. It's going to take lots and lots of clinic conversations to get their A1C in check. All right, so back to our patient, Javier, his discharge plan. So some of the barriers for this patient that's seen in the ER, he doesn't have insurance. He, in the past, has been navigated to outpatient care. Someone gave him the list, but he wasn't able to get in. He wasn't able to do it. So what can we do that's different? We have our substance use navigator who can get them to care and build this bridge, which is the necessary piece.
Yeah, so when we talk about the 3 pillars from the very beginning of California Bridge, what we believe the successful model is, right? Lower those barriers to treatment, get people on treatment, medication first approach. But that second big pillar was the idea of a warm handoff, not a cold handoff. Here's a list, call somebody, good luck. But like, hey, we're going to help you connect. And most clinicians in a busy emergency department or urgent care or whatever don't really have time to like sit and call clinics and arrange these follow-ups. And this is what a substance use navigator does. Now, you might call this something different in your state, it just patient navigator, behavioral health consultant, whatever. There's so many different terms that you could use, but we like to call them substance use navigator, which the abbreviation is a SUN. I personally really love that acronym because they're like shining a light on how we provide this care. But these are, in the California Bridge model, often more a peer resource, not necessarily, it doesn't have to be a trained alcohol and drug counselor, although that's wonderful if they have that training. It doesn't have to be somebody with a master's degree. It doesn't have to be, all those things. It can be a peer, somebody in recovery. It can be someone who had family who went through this and is passionate about it. And their main 2 roles are, number 1, to be a warm welcome, to be an easy to talk to person for the patient in this scenario. Because as mentioned, the healthcare system has not exactly built a long history of love and compassion and trust with this patient population. And so it helps to have a non-white coat, right? Somebody who looks normal, who can speak like you, who understands the journey better than maybe a practicing clinician would, to greet you, to support you, to applaud you for coming in, to help you, to acknowledge that bravery and the vulnerability that you're feeling, and then to make physical connections to your next step. Hey, let's look over the list. Which clinic do you think you want to go to? How are you going to get there? Can I get you a bus pass? Did you know that your insurance provides transportation? Let's call them right now and set up that ride for you. Calling the clinic, getting an actual day and time, and then being able to make sure that your buprenorphine prescription is long enough to get them to that clinic visit. I mean, it seems like a no-duh kind of list, but historically, we just haven't done these things. And having a person who truly just focuses on getting that person from the acute care setting into the clinic setting, and then also from the clinic setting, ongoing care, that transportation issue that keeps arising, accessing their medications and paying for them, all of that stuff, it just really helps to have a point of contact that the patient is given. And so in the California Bridge model, we've seen this look very different at different types of hospitals. It can be a full-time dedicated employee at a busier center, but maybe if you're a critical access hospital and your volume isn't as high, you can have other people who are trained to do this, but who have other roles. Maybe you have a social worker who's a part-time social worker, but also trained in substance use navigation. And that it all has to do with what works for your hospital. We've also seen a model where nearby hospitals in the same community will share a person. If the volume doesn't justify one full-time person at one hospital, you might be able to go together with other sites within, a 5-10 mile radius and share an individual. But really the key is having a designated human being that gets this and can speak the right language in simple, plain language, and be available as a support and be that warm connection in between the acute care setting to the clinic setting.
Yeah, and I was gonna say the take home here is to have staff equipped to facilitate the bridge to care. So yes, as Alicia was just talking about, if you don't have a substance use navigator, so yes, there's grant funding out there. In California, we have the substance use navigator program with the hope of a substance use navigator at every single hospital in California, right? But if you don't have that wherever you're at, utilizing somebody who's interested, right? But this person, we've said the main qualification is that they have to care about people who use drugs and really be able to meet them where they're at. So that's the qualification, right? So if there's somebody who just says, oh, I don't do that, I don't see those patients, that might not necessarily be the right person to do the navigation. Just somebody who's a friendly face, who cares about people who use drugs and is able to relate and talk to them, and really can be that access point. And that's, again, from the emergency department to the outpatient setting. What I do want to note here is what's really, really important is actually just making some calls, because I've had a lot of folks tell me, yeah, this sounds great and all. And you may be saying this right now. This sounds great and all, but there's nobody in my community who's doing this. And my experience oftentimes is that there is somebody doing it, but maybe there's no, the two just haven't met in that community. I can tell you, I simply showed up to a meeting once and it changed my life, because I realized there was an FQHC who was doing this. I had no idea. And that if I started folks in the ER just when they were ready, I would lighten their load. And they were willing to see patients the next day for me, if I would see them and get them started on buprenorphine. It was a great relationship that's now lasted 4 years. And now we have 4 clinics in a rural community doing this. And my substance use navigator, our emergency department volume is 30,000 per year. They're super busy. I need another one to do inpatient work. And it's because we're getting better at identifying folks who need care, and folks are also more receptive to that conversation. So I found that it's one of those cases where you need to build it, and then you will save lives. So it's really important that you have the flexibility, willingness to accept different insurance coverage. So I know we have an agreement that if we get it wrong in the emergency department and refer to a clinic that doesn't accept that insurance, they've always said, hey, we'll see them once. And if we're not the place that they should have ended up, we'll make sure we navigate them there to the right place. It's a warm handoff. It's not a shut door. It's, wow, thank you for coming in. We're going to continue your medication. We're going to make sure you can get to the right place, right? So treat uninsured patients. So there's a lot of grant money out there to support this work, I can tell you that, but it's really important. A lot of folks who are struggling are not patients who have gone and signed up for insurance and have, a ton of resources. So it's really important, as we've said a million times, to meet patients where they're at and make sure you have things in place so that you can see some of the most vulnerable patients. And then, some places offer sliding scale options for visits as well, but have something in place so that you can treat patients who really need this care. So we also know that, there's costs involved with picking up this medication. And I've heard there's a lot of judgment while they're buying drugs and this and that. Yeah, but a lot of my patients are really struggling. So having the ability to have a system with the pharmacy where I know that I called around our pharmacies to make sure that they carried buprenorphine, and they knew we were prescribing from the emergency department, and that if there was a problem with insurance, they would call us, and so that we could do the right thing for the patient. So I can tell you that in California, we have a system where if folks show up to the emergency department and are uninsured, they actually have the ability to sign them up for emergency Medicaid on the spot, and they hand them a slip of paper where they can go fill their prescription. I know in non-Medicaid expansion states, they've made things happen so that there's grant funding for the medications that's available at the pharmacy. So there's a lot of different ways you can advocate for your patients. You just need to know what's going on in your state, in your county, in your community, so that you make sure that all of those barriers are decreased for your patient. And certainly having a navigator, they can take on this and make sure that they create this seamless process for patients. All right, so Javier goes to the clinic now. So I'd like Loni to tell us what happens now.
All right, so Javier goes to clinic. He's out into my world. He's showing up after he was seen in the ER. And it's been a week and he's doing really well. He's on buprenorphine. It's been a week that he hasn't used heroin or fentanyl, and he is surprised. He didn't know this was possible. But he's also starting to have some concern. He heard from friends that some places make you commit to going off the medication. Soon they're going to make he's worried he's going to have to start to taper. So I want to address this. Evidence shows that continuing and maintaining a patient on buprenorphine is the standard of care. It has the best outcomes, and it is the best chance Javier has at remaining stable and being in treatment at 3 and 6 and 1 year mark. So it is the thing that we should be doing, and all of our counseling and conversations to the patient should be encouraging them to stay on their medication. I would never start a patient on blood pressure medication, but then right off say, yeah, but we got to get you off of it. what I do is I start patient on a blood pressure medication and I consider my job well done. Great, stay on that. It's working. Long time down the road, if they pick up diet and exercise, we're able to slowly taper off. Great, but most patients remain stable on their medications, and we consider that a job well done. And that needs to be our messaging to patients, that this is the thing that's going to keep you stable. I can't tell you how many heartbreaking times I've seen people whose family or significant other or probation officer, someone decided that this medication was not the right thing for them, and they tapered off and they relapsed. The thing that is making them the safest, has the best chance of them not dying of an overdose, is staying on this medication. So that needs to be our very clear messaging. So when Javier comes into clinic, the first thing I do is reassure him. I say, hey, we'll talk about that later. Right now, I want to keep you stable. I want to help you get a driver's license. I want to help you get back to work. I want to help you build and maintain relationships. I want to help you get your kids back. All these things of rebuilding life are the thing to focus on right now, while this medication helps provide stability. So the other thing is that people say, you know, you're not really clean and sober if you're on this medication. And in the same way, that is a myth we need to dispel, that we would never say you're not managing your blood pressure in the right way if you're on a blood pressure medication. We would say, are you adherent to your blood pressure medication? Great. So our messaging needs to be clear on this. So for patients who experience return to use, we need to be there to support them. This is a patient that now is connected with me, and they know that if they're struggling, if they're back using heroin, they can call my clinic. They can walk in at any point. They don't always have to go back to the ER and withdrawal. This is an opportunity for them now, with the relationship we've built, for me to call them and say, let's do another home start of buprenorphine. Let's see what it's going to take to get you back stable. And so the chance to build these outpatient relationships, so that if there is instability or relapse, they can continue to engage with our team. We can give them tools, relapse prevention tools, and get them past this. And so addiction is a brain disease that manifests as impaired impulse control. As you see in this slide here, it is not something that we expect people to stabilize all at once. Relapse is an expected part of this. And so, Alicia, I'll let you explain a little more.
Yeah, so I just think this is, you know, what we know about opioids is that they activate our reward center, right? There's a reason we get addicted to these things, because it feels freaking awesome to be high. Like if I didn't, nobody would do it. You know what I mean? So it's similar, though, the same reward that we get when we do lots of things that are terrible for us. Like instead of exercising, sitting around and binge watching Netflix all day, or eating ice cream, or, you know, having potato chips instead of carrots as a side to your dinner. I mean, we as humans, unfortunately, evolution has made us, the primal piece of us, wanting to fuel that dopamine system, that reward system. And so if a patient came in with relapse and we shamed them, or we taught them about failing or something, that would be like if every single time that a patient, you know, ate something they aren't supposed to or didn't exercise, that we were shaming them. And instead, right, we're always trained that we have to have a conversation about changing lifestyle habits and trying to do better, but that relapse is actually a part of it. And for us as the provider, being able to tell a patient, hey, this doesn't mean you failed. Like returning to use sometimes, that is a part of it. That is a part of it. And you're not bad. And let's talk about what happened. What triggered that for you? What did you need that you didn't have in that moment to not return to use? Could I help you? Could be, you know, do you need group support? Is your medicine dose high enough? What is it? And trying to take it from a problem solving perspective instead of, again, this idea of like firing patients from treatment, which unfortunately is very common in a lot of communities, is that if a patient relapses, they get kicked out of the clinic or kicked out of the program. And that's just kind of insane. Same with, like Loni was talking about, trying to get people off of treatment. That shouldn't be the goal either. Most people who need medicine for chronic diseases need that medicine chronically. And yes, some people will wean off and come off, but not everybody. And so that shouldn't be the goal. The goal should be stabilization, and then working with that particular patient with their own goals. And while we're talking about Javier as like, you know, this example, he is every patient. He's every patient. 28% of patients out there have a substance use issue. Every patient out there has a story to tell. All of us have been negatively affected by COVID-19. All of us have, struggled more with access to care. Every patient is having a harder time, is scared to go into a clinic or an emergency department because they're worried they're going to get COVID. Or like all the clinics are full because, on our side of things, we've shut stuff down or increased PPE usage or decreased our availability of clinic appointments. This struggle that Javier is going through is normal. This is an every patient problem. And that's why it should be an every provider problem. So we want to take a beat to talk about some of what I mentioned at the very beginning. We, California Bridge and Atlas on our own came up with some of the very same ideas of what does it mean to create a quality and efficient care system, a good model that is evidence-based for these patients. And so here are some of the Atlas quality measures. We won't read every single one of them, but you'll notice that there is some overlap. We've been talking about fast access to treatment. A patient should be able to walk into your primary care clinic, come into an ER and withdrawal, whatever it is, when they're ready, right patient, every time is the right time, every place should be the right place to take a medication first approach. So having that access to medications for their substance use disorder instead of just a list of resources and a good luck. We know that fast access to treatment, good access to medication for addiction treatment leads to better outcomes. We've shown you multiple studies and slides that showed that it literally decreases death in these patients. And we've had, we could go on all day with the anecdotes of patient stories that we have that demonstrate this. People returning to jobs, getting custody back of their children, feeling normal, getting friends again, being reinvested in their family. Just all kinds of incredible, beautiful stories because we took that approach. Personalize your evaluation and treatment plan. There shouldn't be a standard. Every person must do this every time. My patients only get to be on 16 milligrams of bup a day, and then you have to wean off. That's insane. We don't say that, lisinopril 40 is the only blood pressure regimen out there. And so we shouldn't be so regimented in our approach to substance use care either. Think about long-term treatment and follow-up. It's the same model as any disease. The ER's role is stabilization, and then we hand off in a really well delineated way to our outpatient colleagues who have a plan to customize for that patient and have that follow-up available. Think about also coordinating care for mental and physical health. We didn't mention this in our model, but the idea of being connected to your community, of having a substance use navigator who knows your community partners, is that they could also address some of the other comorbidities that we often see with substance use issues like depression or anxiety, bipolar, schizophrenia, whatever. There's all kinds of things that we see comorbidities, and we want to make sure we're thinking about the whole patient as one patient and not just putting all their care in little buckets with nobody ever communicating to each other. And then having effective behavioral therapies for addiction. So I mentioned this, we should not be mandating NA or small groups, but we do want to make those things available. And we do want to think about how we can do other pieces of care that aren't just medication, but it should be medication first as the active stabilization step one to their care. We want to make sure we have additional services to support recovery, the list that we've been making. And really what we're trying to say is, if you make it low barrier, easy to access, evidence-based, medication first, that's how you develop a quality and efficient care system for these patients.
All right, so I'm going to talk about some key takeaways. So we're going to wrap things up here, but I want to leave on a personal note. So my sister died from the effects of drugs. And at the point in her life where she was the most high risk, kind of the most unstable in her disease, she was not making appointments in primary care clinics. She wasn't going to any clinics or making any appointments at all. She was primarily seeking her care in emergency departments. And I often wonder, what if there was a system like what we described that was there for her? So I'm set on making sure that we teach people how to make these systems, because wouldn't it be beautiful if somebody could just wake up in the morning, decide that today's a day, I'm done with using this drug, and knew that they can go to an emergency department. They can go anywhere and get high quality treatment. That's what we want. So your key takeaways here, we want patient-centered, rapid access to addiction treatment. That's an essential component of quality care. We have to make it really easy for patients to get treatment. right? We want to increase the numbers of patients who are being started on buprenorphine and EED, and that they're referred in that warm handoff kind of way to treatment in the community. Know what's in your community, know what resources are there to support your patients. This patient, what if it's your sister? You would want that person to have all of these resources available and known, knowing they're not in a position necessarily to find all these siloed places, right? And then again, you want to make sure that you're providing this quality patient-centered care and that you're creating the shift in culture in emergency departments. So it's a warm, welcoming place. So there are certain action items that I want to talk about as well. Things that you can do, that you can take away today, right? What can you do to create this system that's going to save lives? So you can connect with leadership in your local emergency department to establish a referral process. That's how I started my program. It was a meeting and somebody told me all about addiction treatment and what we could do. And I said, oh, I could do that. I could give a medication that works. Perfect. And as long as you'll see them, within 72 hours, we created a system that to this day is still functioning 4 years later. So, and that's because we remove barriers. So scheduling, payment options, we want to make sure all of that's really easy for a patient, so that always take the perspective of what if I were the patient? What if that patient were my sister? What would I want that to look like for them to follow up? And you'd want to remove all of those barriers, because this is a heroic moment in their life where they're seeking treatment. It takes courage. So we want to make sure we reward that courage with having an easy system. And again, we want to standardize patient-centered treatment plan that includes early stabilization, that their opioid withdrawal is an emergency that can be stabilized in emergency departments with the right medication. So I hope that you can take those things away, you can get a program started. Now we have a ton of resources because we're so passionate about this work. We have spent the last few years trying to think of every barrier, everything, every question you can have, and we've developed a ton of resources. So please, this is another QR code. We know that you've done this in restaurants where you take your phone, but you can scan here. If you have trouble scanning, then it's cabridge.org. Please go there. There's an on-shift tool for the emergency department clinicians. A ton of resources, including patient-facing things like patient education, how patients can start at home. So a lot of great tools in there. There's a blueprint, a toolkit, etc. So please make yourself or educate yourself on all those resources. It can be really valuable. And like I said, thank you for your time today. Join us. We love to talk about this. Clearly, we can't stop talking about this. So we do presentations all the time. You can join our email list for announcements. We really try to get all of the information out there so that you can have a very successful program wherever you're at. So thank you again for your time today. I'm super grateful for this amazing panel. We do literally put our phone numbers here just in case you want to contact us and talk to us about how to do this in whatever setting you're in. So thank you.
Wonderful. Well, my sincere thank you to California Bridge and to Arianna Campbell, Alicia Gonzalez, and Loni Jay. Just a wonderful presentation. Really appreciate your time, everything that your organization is doing. It's clearly providing value and clearly saving lives. So thank you very much. So this will conclude our second webinar in our Continuous Quality Improvement Learning Series. We will have a follow-up session to this that will follow a similar format to our prior sessions, in which we will have a more robust Q&A. So please, I'm sure many people had many questions or comments. We'll have additional time for that in our subsequent webinar. Thank you all very much. And again, my sincere thank you to the folks at California Bridge.